Dr. Jones is the CEO of East Arkansas. She's also an internist, and she has been practicing firsthand in this model. So she's going to tell you a little bit today about East Arkansas, about her experience with CoCM, and about their work, as well as the rest of her care team. And so I'm going to pause there because I know we're on a time limit, and I'm going to turn it over to Dr. Jones, and she's going to tell you a little bit about East Arkansas.
All right, good afternoon, everyone. Can you hear me? Okay, good. So as stated before, I'm Dr. Susan Ward-Jones. I'm an internal medicine physician, and I've been the CEO of East Arkansas Family Health Center for some 18, 19 years. Prior to that was 10 years as a medical director. So happy to be here today with our team today. And my job today is to really let you know who we are, East Arkansas, where we're located, and then also our mental health, behavioral health journey. So this is our first slide, just the Behavioral Health Integration Conference that we're here today. And I would be remiss if I didn't really talk about just all community health centers of Arkansas. And this is just a map representing all the health centers across the state, representing over some 250 clinics across the state, representing some 300,000 patients across the state. So you can see there are 12 individual health centers and actually dispersed across the state, representing many clinics, and we're located on the eastern side of the state. We actually have 12 service delivery sites and 3 retail pharmacies, so we go where areas of need. Now, our mission is to provide accessible, high-quality, comprehensive health care to our communities, one patient at a time. By 12/31/2026, we will be a leader in quality health care, patient experience, and workforce engagement. Our core values are accountable to all, respectful of others, dedicated to our mission, compassionate toward everyone, innovative in our approach. Our brand promise is quality service, quality health, quality life. And this is just who we are. We are a community-based organization, a federally qualified health center established in 1974. We just recently celebrated 50 years of operations. As I stated before, actually we have our 8 service delivery sites, 3 school-based health centers, 3 retail pharmacies, an HIV/AIDS case management office, and a medical mobile unit. The total patients that we served in 2024 were 22,078, total encounters of 73,000. We are a HRSA Health Center Quality Leader designation for the past 6 years. We've been Joint Commission accredited since 1997, and also we have NCQA PCMH accreditation, patient satisfaction survey of 93%, employee satisfaction survey 86%. I guess we have a little bit to work on. Also, we have primary and dental care, behavioral health, vision, chronic disease management, women's health care, pediatric care, HIV/AIDS management, nutrition and diabetic counseling, in-house lab and x-ray. We have 2 in-house pharmacies, and we're proud that we provide transportation for all of our patients for their primary care visits, as well as their specialty care visits, and also we provide preventative care. We have a staff of 273 that includes a number of providers, physicians, nurse practitioners, ophthalmology, pediatricians, LCSWs. We have 7 dentists, 1 dental hygienist, 9 pharmacists, diabetes educator. We have case managers, and we have our beloved clinical informatics nurse that's here today, Lavanya, quality adherence nurse, referral specialists, care coordinators, community health workers, and community health navigators, you know, with a support staff of 208. So it takes all of us to make all of this work. This is our flagship site in West Memphis, and of course we were established in 1974. And really, this picture, you really need to see where we came from. We've been in this site for about 10 years, and you would not believe where we were before. I'd like to say that we went from the pit to the palace. This is our Lepanto Family Health Center, and I want you to get kind of a feel of our communities in which we serve. This site was established in 1976. This is a population of probably about 1,200 at best, when everybody's at home, I guess. But also, this is an old hospital. Some of our employees there were actually born in this facility. This is our Arkansas Delta AIDS Care Center that was established in 1998. We saw a need to take care of the HIV/AIDS population. We have Ryan's White Part A, C, and D. We're very proud of our program that serves that population, and this is a support case management unit. This is our site in Blytheville, Arkansas, in Mississippi County, established in 2009, Healthy Partners. And this is also Truman Family Health Center, located in Poinsett County, established in 2010. Actually, we took over this site. A family practitioner came to us and wanted us to take over operations, was tired of just the overhead, so we took over operations there. And on the right, you will see the medical clinic, and on the left is actually the dental clinic as well. And this is our flagship in Helena Family Health Center, and of course, this was established in 2012. I am a product of this community. My mom still goes by there and tells me what's not being done right, and she's 89 years old. And actually, I used to receive services when I was younger at this site, so it does me good to be able to come back and contribute to the community in which I'm a product of. You can see on the left is the medical clinic, and on the right is our flagship dental clinic there as well. Earl Family Health Center, near and dear to my heart. My husband is from Earl. We lived in Earl for 1 year, when we got married. He grew up there, but this was established in 2015, and if you'll see towards the right of it, in the back of the building, actually is the Earl Church of God in Christ, where I go every Sunday for worship services. This is ASU Mid-South Community College. This is our school-based health center there. We see college students there on a weekly basis that was established in 2017. And this is East Arkansas Family Health Center Marvel, that's located in Phillips County as well. This was established in 2017, and there again, this was established out of a need. This is not in our service area, but the mayor of the town came to us and asked us first if we would take over billing, and then he asked us would we take over services there. So we go where there's a need, and of course, Marvel, Arkansas, again, probably does not even have 1,000 people when everybody's at home. Marion School District School-Based Health Center, established in 2018. This was out of a need. The principal there, I don't know if anybody know Dr. Glenn Fenter, but you can never tell him no. So we had no experience in opening up a school-based health center, but today it is a thriving health center. This is the Forest City School District Health and Wellness Center, established in 2023. Again, out of a need. It's not in our service area, but we were asked to come in and provide services there. And actually, a second site is being constructed there on the campus as well that will open on this fall. And this is East Arkansas Family Health Center South, established in December of 2023. This is our women's health unit, and our FPOB actually started here yesterday. And this is our Delta Health Mobile Med, and you may see a couple of, maybe one familiar face, but we decided not to get stock photos. We wanted to traverse the Delta and make, and people can understand who we are and resonate with people that they know. This is the clinic, this is the East Arkansas Family Health Center Marvel Pharmacy, and was not looking to open this. The city, out of a need, the pharmacist left, and we opened this this pharmacy in 2020, and I had a physician that questioned, did I know what I was doing? And, I didn't tell him, but I didn't. But this, to be honest, this pharmacy is thriving. And then this is East Arkansas Family Health Center Pharmacy. We just purchased this last year in the summer, Helena, and actually this is located close to the clinic that we have there, so we have plans to kind of make that a medical mall, just to kind of make that one-stop shopping. This is East Arkansas Family Health Center Pharmacy in West Memphis. Just purchased that actually about 6 months ago out of a need for the community and to provide another access point for our patients. Now I want to talk about kind of pivot our behavioral health program and how we started. Our behavioral health program began in 2014 with the Mental Health Service Expansion Behavioral Health Integration Grant in the amount of $250,000 that allowed us to hire our first LCSW, and she sits with us here today, DeWarna. And then also we bought equipment and training and also contract telepsychiatry services. Then we got an Ames grant in 2017, access increase in mental health and substance abuse in the amount of $150,000 that allowed us to hire 2 case managers for mental health and substance abuse. And then we received another grant, the Mental Health Substance Use Disorder Expanded Capacity Grant, that allowed us to get another LCSW, a .25 psychiatrist, equipment, training, and also a vehicle for patient transportation as well. And then in 2020, we received the Integration Behavioral Health Services Grant that allowed us to get another LCSW and a community health worker and a psychiatrist as well. Now, these are our behavioral health program statistics. 2024, our behavioral health staff comprises of 4 LCSWs, a psychiatric nurse practitioner, 2 case managers, and of course, these are all of our screenings for substance use disorder, our mental health patients, expert screenings, depression screening, and craft screening. And what you have to understand is that this is implemented at the time of vitals check-in. This is a part of just if we check the blood pressure at least once a year and on demand, then we're going to do those screenings to make sure that we capture those folks that need access. So we're very proud, and I won't say that it's been maybe an easy journey for us. Just because we really tried, I won't say easy, but easier because we have tried to assemble a team initially and try to get those things in place to make sure that we could have a successful integration program. There has to be buy-in, and we'll talk about some of that in some of the panel discussion, but I think that, while we've tried to assemble the staff, of course, staff is always an issue in terms of trying to hire LCSWs and nurse practitioners. Matter of fact, we're looking for a psychiatric nurse practitioner at this point now. So you can see the number of patients that we have, the expert screenings, depression, and also craft screenings as well. We screen anyone over 12 years of age for our patients, and I think for us is getting everyone on board. I actually have one of my nurses and she's my nurse, and she does that PHQ-9, and she always tries to help them. Like, no, you don't help them get a better score. We need to understand what their score is. So just constant training and understanding of how to really use those screening tools. And then also, I want to talk about our collaborations and our research studies besides the collaborative care model that we're in now. Back in, through the Patient-Centered Outcomes Research Institute, back in 2016 to 2021, we were involved in the SPIRIT grant. And that study was to promote innovation in rural integrated telepsychiatry. And it was conducted in 12 FQHCs, 1,000 primary care patients screening positive for PTSD and/or bipolar disorder were randomized to collaborative care management with support from a state medical school telepsychiatrist or referral to state medical school telepsychiatrists and telepsychologists. Patients in both groups experienced large decreases in symptom severity and increases in mental health functioning with no differences between groups. So primary care providers such as myself generally prefer this collaborative care management model, and it required really 1/6 of the time of specialty mental health provider time. So thus increasing access, and providers really understand and really like this model. And then in the steps, and anybody knows Dr. John Fortney, you can never tell him no, and we never told him no. So thus we were in the STEP study from 2020 to 2024, just finished up with that loan last year. But the STEP studies was conducted in 7 FQHCs dispersed throughout the country in 8 VA medical centers, both using the behavioral health consultant model of integrated care, the Cherokee model, which we've been trained in, with 700 patients with PTSD were randomized to receive one of 3 selective serotonin reuptake inhibitors, sertraline, fluoxetine, or paroxetine, prescribed by the primary care provider, or 6 30-minute sessions of trauma-focused psychotherapy, written exposure therapy. Patients in both groups experienced large decreases in symptom severity with no differences between groups. So we can see that both trials really clearly demonstrate that it's feasible to treat these more complex psychiatric disorders in primary care settings, and that patients benefit clinically from integrating mental health care into primary care settings. Now, I will talk about this article of the year, and I think it really was Dr. Gibson that brought, we do things and don't realize the importance. And as a CEO, I'm just trying to provide access and share best practices. But in 2016, East Arkansas Family Health Center and the University of Washington began collaborating on that Patient-Centered Outcomes Research Institute grant to compare, telepsychiatry integrated care model to a telepsychiatry referral model for patients with bipolar disorder and/or PTSD. Myself co-authored along with Dr. Jordan Fortney on the first article that describes how to set up a telepsychiatry program in FQHCs, and I don't know how this happened, but the manuscript won the article of the year. So you can see there was an official letter dated March 28, 2019. So, it really is of value when we get involved in these studies. And for me, it's not about the article of the year. It's about providing access to our underserved patients and lack of resources in the Arkansas Delta. So, we will always be that entity that Dr. Hudson and Dr. Fortney and, everyone else, and Dr. Gibson, and she's, this morning, she cornered me this morning at 8 o'clock. Susan, we got to do this, we got to do that. And I'm like, okay, let's go. So I'm excited to be a part of it, excited to be here today, and we'll go further into the panel discussion about our program. And the last slide by Maya Angelou, people will forget what you said, people will forget what you did, but people will never forget how you made them feel. Thank you.
Thank you, Dr. Jones. Wow. So for me, this is one of the most exciting parts of the conference. I love to hear from the people on the clinic who are actually doing this work. We brought in national speakers. You've heard about all these amazing studies, all the great work that's happening. But now this is really an opportunity for us to hear what's happening in Arkansas. And there is a lot happening in Arkansas. And I just have to say, this is a dynamite team, and the work that they have done in the past year has truly been phenomenal. And so we're going to let you hear from them. I don't want to steal their thunder or talk about this because I really can't put into words what they have done over this past year. So we're going to start, and we're going to talk to first, Dewana Smith McNeely, and Dewana is their behavioral health director, and she's in the red jacket. She was that first LCSW that they hired with that grant, and Dewana has really been leading the charge for them as far as how do they pioneer behavioral health programming. And so we've got a couple of questions for each of the panelists because we want you to hear from them. This is team-based care, and we want you to hear, how does my role impact integrated care, specifically CoCM? And so, as we said, Dewana is an LCSW, their behavioral health director, and so she has seen the behavioral health program from the beginning to where it is now. And so, Dewana, I want to ask you, would you tell us what brought you to the decision as a clinic to add the collaborative care model to the services that you're currently providing? Let me pass that.
Thank you. We're fortunate enough to have Dr. Jones as our CEO, and she's also a provider. So she sees firsthand what's needed with the patients. She doesn't hesitate to look for any services or access to services to enhance what we can provide for our patients.
But I want to ask if you could talk a little bit. We heard this morning about different models of integrated care. We heard about the PCBH model, or primary care behavioral health, and we know that you've been doing that a long time, and you've also been serving yourself as a behavioral health consultant. Would you talk a little bit about how CoCM complements the current services you're providing, and a little bit about the continuum that you have and how CoCM is adding to that continuum?
Okay. We started with PCBH, and what I noticed when I first started is that the ability to refer patients to specialty mental health, the limited ability to refer patients to specialty mental health. There's so few behavioral health and mental health providers in our area. What I found is not only was I doing PCBH, but a little specialty mental health, and with adding CoCM and the primary focus being on anxiety and depression, having someone else to provide treatment to those patients who are experiencing mild to moderate anxiety and depression freed up a little additional time for me to devote to patients who had more complex mental health issues.
I just wanted to follow up and say it's not uncommon for us to hear that CoCM is often best used for mild to moderate needs, and so you speak to that beautifully, and that's what the research is telling us, that's what the model tells us, and so you definitely articulated that, and it's good to hear it's not just something we're reading about, but something that's happening in practice.
And our next,
I'm Lavanya, clinical informatics nurse at East Arkansas Family Health Center. So my role in implementing CoCM was to work on the workflow with EHR, electronic health records. So we have ECW. Also work with everyone up here, just trying to make sure that they do their role and can complete the plan. Also assisted with setting up the AIMS registry. I know a lot of speakers have spoken about that, so I helped create the accounts for that, make sure everyone have a user type that fits their role for that. Also recommend workflow recommendations. So if there's something that they need assistance with, I help them with that. I also help with data. If there are some reports that they need, just implement CoCM, we had to see how many people has anxiety, depression. Is this something we want to do? So that was another part that I did.
and from your perspective, what are the essential components for setting up a successful integration?
Some of the successful components are just having clear goals, effective communication, having a team-based approach, which we have, being able to communicate with different people on the team. We also have bi-weekly meetings with the AVEN committee, and we speak on our concerns, questions, and we give feedback, and we're just trying to keep the conversation going so we don't forget what we're doing and keeping a plan in place. Having our leader buy-in to complete the process. So sometimes, new processes, people need assistance. So I also help to create a referral process because there has to be a consent, which I think another speaker spoke about consent from the PCP. So we work with eClinicalWorks, and they have a clinical engine rule, and it allowed me to create a rule. So if a patient scores 10 on the anxiety or depression screening, a referral will automatically be created and sent to Kiara, and then she can reach out to that patient. So that was something they didn't have to do. So with new processes, sometimes providers need reminders, and that way they didn't have to be reminded to do that process.
So what are the parameters of your specific CoCM program?
Our parameters are anxiety, depression, mild to moderate, and we're working with ages 18 and up right now. And we picked that because they were the top two areas that we want to focus on at the time. And also, like I said, we're doing GAD-7, and we'll look at the score of 10 or greater for that and depression. So that's it.
I was going to say, Lavanya, you cruised through that, but let me just say, we said, Lavanya, we need you on this panel. And part of the reason we wanted and needed Lavanya on this panel is because she has truly been so instrumental in helping set up all of these technical programmatic pieces. And, you know, we talk about, oh, this is exciting, we have this opportunity to implement this new model, but this is really, really hard. And one of the things that we hear when we're talking to clinics is they have an EHR, and how do they get that EHR set up so that they can pull the information, they can get the reporting needs. Anybody who's ever worked on a federal grant knows there is definitely reporting that happens. And Lavanya's been doing all of that. And so it's absolutely essential to have someone like Lavanya. And Lavanya, I just want to ask if you could give advice to someone who was just starting this in their clinic. What advice would you give to them about working with the EHR and setting up some of these programmatic pieces?
I would say, I guess, having a relationship with the vendor that you use, because sometimes you have questions about, what does the EHR do, what is it capable of, and just having a guide, someone you can speak with. We also work with, we're part of CACA, so we communicate with different people that use eClinicalWorks, and it's like, have you done this before, or how does this work? So we just kind of collaborate and find things that work for us, and just asking questions. So I also reached out to you. So I think Dr. Saderi, there's a psych consultant we work with. She also has some experience in ECW, so I was able to speak with her about how the workflow works with her, with their clinic in the past as well, so they help.
And I would just, can you hear me? Okay. I would just add that, not to just, I'll give Lavanya her kudos, but when you're trying to set up this program, it's really essential, if you can, to have such an entity as Lavanya that can scrub the data and make those connections with the EMR. And, she often talks over our head, and we're like, Lavanya, come back this way. Because she's so into it, and she understands that world, and you really need someone that understands it. So this is part of the success. It takes all of us to make this work, but her role is a critical success to our program. So I would implore you to, if you can, to hire such an entity. She's not low cost now, but she's well worth it though.
Thank you. Okay. That's awesome. Can you hear me? Yes. All right. So you heard a little bit from the administrator. We have Dewana, and she's really serving under Dr. Jones as that behavioral health director. We've got Lavanya, and she is helping with the programmatic pieces, the data, scrubbing the data, the analytics, all of those pieces, setting up protocols and workflows, and I can tell you, none of that is easy. But now we're going to talk a little bit with Kiera. And we have Kiera. Yes, we've got Kiera. And sorry, I was looking to make sure I didn't lose my place. We've got Kiera, and Kiera is the behavioral health care manager. And I have to say, we've had an opportunity to really get to know Kiera. And in this model, the behavioral health care manager is the quarterback, or oftentimes we refer to them as the glue. They're keeping all of the pieces together. And so Kiera not only Well, I'm not going to steal your thunder because that's my question. I've got to ask you. I'm getting ahead of myself here. But Kira has been working in this role, doing a phenomenal job. And so, Kira, we want to ask you a little bit. What was your journey to the behavioral health care manager role, and what does the behavioral health care manager role do at your clinic?
All right. Good afternoon, everybody. So as the behavioral health care manager, I wear many hats. I play care coordinator, so I work closely with our consulting psychiatrist and our primary care team. I do patient education, lots of psychoeducation about things like diagnosis, different treatment options, symptom management. I do a lot of support for medication management. So my patients who are taking medication, I tend to check with them and make sure that they're adhering to the medication, the prescriptions rather. And this looks like taking it as it's written, because sometimes we know patients have a hard time with that. I do a lot of collecting of data, so I use assessment tools to collect patient data, and then I upload that data into an online registry, and we use AIMS for that. And of course, I do the brief therapeutic interventions, so these are things like mindfulness, motivational interviewing, behavioral activation, things of that nature. So, and I came from specialty mental health, and so the journey to primary care behavioral health has been a little different. Should I talk about the differences?
Yes, I would love you to talk about the difference.
Okay, so the main difference for me as the behavioral health care manager, the timing. So with traditional therapy, you're going to meet with the patient anywhere from 30 minutes to an hour, just depending on what the service is. With CoCM, I'm allowed 60 minutes to 70 minutes for the entire month. And so sometimes that looks like a 30-minute session here, a 15-minute phone call here, a 7-minute phone call here. It just needs to total 60 and 70. Another difference is the convenience of collaborative care. So collaborative care has made behavioral health care more accessible in rural areas and underserved populations. Also, it's convenient in that our patients can come into the primary care clinic and they can see the behavioral health care manager at the same time. So it reduces the need for multiple appointments and going multiple places. Another difference is the care team. So traditionally, the therapist leads the care, but with collaborative care, I'm working on a team with the psychiatrist and the primary care physician. And so it's, we have people from a background of behavioral health and medical health. So it's just better to treat the patient overall. Let's see. I have a couple of differences. The focus of care is different. So primarily with traditional therapy, we're focusing on behavioral health only, all things mental health. With collaborative care, it's more providing resources for different things. I do everything from helping with coping skills to the management of chronic diseases like diabetes and things like that. The last one is for me, the emphasis on measurement-based care. Traditionally, we are supposed to rather have measurement-based care, but traditionally treatment is driven, in my opinion, by clinical judgment and a lot of patient report. And so with collaborative care, there's a big emphasis on using those measurable tools, using the GAD-7, using the PHQ-9. And what I found is that over time, I can see the trend and I can better tailor my interventions to help the patient.
Would you be willing to share a success story, a patient success story?
Okay, so I have a young man who came to me with anxiety. When he first came, his GAD-7 was, I believe, at a 19 or 20. I worked with him before because he didn't want to get on any medication at first. So I worked with him maybe a few weeks, maybe 3 or 4 weeks or so, and we didn't see a whole lot of improvement with the medication. And so once I brought it to psych consult, he got, I think it was suggested that he start sertraline, if I'm not mistaken. But he started the medication, and since then, his PHQ-9 scores have went down significantly. We don't meet as frequently. I was calling him weekly, but we don't have to talk weekly. And every time that I talk to him, he's got something positive to say. And so it's a big difference. He also doesn't smoke weed anymore, so that helps. That helps. So.
So it sounds like in this model, you are quickly able to see this measurable difference when patients are improving.
Yes, yes.
Fantastic.
Wow, that's some good stuff y'all been sharing. So now we're gonna go to Cyril. Cyril, you're one of the psychiatric consultants in the CoCM model at East Arkansas. What attracted you to practicing in this model?
So, hello everyone. Is that too loud? Is that okay? Okay. Sounds loud to me up here, but either way. My name is Dr. Cyril Appiagyei. I'm a psychiatrist. I'm based in Chicago, Illinois. I do general adult psychiatry. And there's a few things that attracted me to CoCM. So, I had the opportunity to train at a great program that we saw a lot of, individuals, a lot of patients. We had a lot of sort of quote unquote repetitions. So felt like I got to really train my skill. That said, I think in terms of, outpatient care, the place where I trained, many of the individuals we saw, they had at least some means, right? And many of the people who trained us to do therapy, they typically had their own private practices, long, well-established things they enjoyed. They did a lot of good work. But I think my experience in residency, working in the emergency department, working on the inpatient psychiatry unit, and even doing outpatient care, just seeing that there really was a lack of access to care, people having to, go to those acute care settings because they couldn't have providers in the outpatient setting. And while I enjoyed what I do, and I still enjoy that work because I still do some of that work, like many of us here, I wear a couple hats. I still wanted to find a way to work in a model that could increase access to care. Kind of like Dr. Kate said earlier, in mental health care, there really hasn't been a change in suicide rates or inpatient psychiatric admissions or encounters with law enforcement related to mental health. So really thinking about, okay, well, how do we approach this in a different way to try and enact change? Some of the things specifically about the collaborative care model that I liked was that it actually increased access to care. I think there are a lot of other models out there and they work well, but they don't actually increase access to care. And I think that part of the way the collaborative care model increases access to care is that I am not necessarily directly seeing patients, right? But that is a big mindset shift that's very different than how I train, that's very different than the status quo. I think, like when I think about myself personally, I do enjoy seeing patients one-on-one. I think there is a certain gratification that comes with that, but I can only maybe see one person in an hour for an intake or 2 to 3 people in an hour for a follow-up, while in collaborative care, some studies have shown that you can learn about, 10 people in an hour, and that's almost sort of exponential in how you can increase your reach. I also think, again, I like my job. I think I'm pretty approachable, but when somebody has to come see me, they're typically referred from another clinic. And that means they have to go to a new clinic, they have to meet a new provider, they have to start all over with someone. And especially with, the subject matter of what I deal with, even though, I'm a psychiatrist, and again, I like to think I'm approachable, that's difficult, right? You have to go to a new setting, you have to meet somebody new, you have to build trust with them. And then on top of that, right, you're probably gonna take 3, 6, 9 months to get to see me either way, right? Which is another barrier, I think, in traditional care that collaborative care sort of helps us get around, just because you can see so many more people. And I also like the fact that it was shown to be effective for, elderly individuals, women, people from different backgrounds, people from rural areas. In Illinois, I think in our healthcare deserts, there's about 1.2 psychiatrists for every 100,000 people, while the state average is about 10 for every 100,000 people, while the recommended is about 25 for every 100,000 people. So there's just this large gap. We're never gonna train enough providers to really tackle it. So figured we have to start looking at different models. I'm rambling now, so I'll let you continue with your questions.
Well, you just said that you aren't seeing the patient yourself. So exactly what do you do as a psychiatrist in the CoCM model?
That is a very good question. So the way I kind of structure, I work with Kiara, then my other half, Jason there, who's also a psychiatric consultant. So typically how it works is, we have the AIMS registry, so we have a panel of patients we've been putting on that registry. And then, I am able to go on the registry and look at what their most recent scores are, when the last time I talked about them with Kiara was, and when the last time Kiara was able to do outreach with them. So that allows me to sort of stratify and triage, who needs to be discussed and talked about, right? So that's going to be individuals with the higher GAD-7, PHQ-9 scores. That's going to be individuals with, safety concerns. It's going to be individuals who it's been a while since we've been able to reach out to them. So then we can sort of plan our session ahead of time and say, okay, like these are the people that we're going to prioritize. And then during the session, if it's a new individual, Kiara's had the opportunity to meet them, to do a full intake with them, and she sort of synthesizes that and talks to me about that, and then we kind of game plan together to come up with a plan. And that could look like, that could in some cases be watchful waiting, in some cases that could be sort of a brief intervention, or something like behavioral activation or problem-solving therapy. And another situation that could look like, well, what are the community resources that are available? And then another situation that could look like, well, hey, how about we talk with the primary care provider about prescribing, sertraline? And I think a lot of what we actually do together is also talk about psychoeducation with patients as well. So I think when they're learning about, themselves, and they're learning about how they're feeling, and then they can, sort of have a different way to think about it and approach certain things they're going through as well. And then, so that maybe takes up the meat of what we call the systematic case review, also known as the quote-unquote secret sauce, but that's really I think the meat of Kiara, the behavioral health care manager, and me, the psychiatrist, sort of interaction. And, I think it's a relationship in that, we're always thinking about, how our process is going, if there's things we need to change about our process, if we need to be creative. Yeah.
Awesome. What a great explanation. I'm so glad you talked about the secret sauce, because the more and more we learn about this model, that's truly what we hear. And I think, really, to me, the secret sauce is looking at the two of you, you're interacting with each other, you're really engaged, you're smiling back and forth, and you've built that trust relationship. And you're getting that information all throughout the team. And so if Dr. Jones sees a patient and she says, I think this patient can benefit, and they get a referral to Kiara follows up with them, she's then not only engaging with that patient, but she truly has this back and forth relationship with Dr. Appiagyei, where she's able to do a quick 5-6 minute case presentation. He's able to look at the records, and they're able to get that patient care and help in real time. And so I love the secret sauce. To me, that's one of the biggest pieces of this. Okay, and now we've got Dr. Onawa. And Dr. Onawa, you are also a psychiatric consultant with East Arkansas. And you're working with the team as well. One of the things that we've heard about today was workforce shortages. And so we know in Arkansas there are definitely workforce shortages. And so would you be able to talk a little bit about how the CoCM model expands access to care? Oh, and any challenges that you see in the landscape?
Yeah, most definitely. So I'll start with the challenges. I think when you think about delivering mental health care and the things that Cyril mentioned and the rest of the team talked about for collaborative care, is that it's team-based, right? And something I always think about is that it takes a village, right, to raise a child, but it also takes a village to care for people. And when I think about how collaborative care changes that dynamics, Cyril mentioned it. When you're doing case review, if I'm seeing patients one-on-one, I'm limited by the amount of time that I have to really engage and affect change in that person. However, in this model, we're implementing things like, universal screening, where patients are coming to spaces that are less stigmatized, that they feel comfortable in, that they've built a relationship because East Arkansas is so engaged within that community, so that they're able to pass that barrier of stigma and be able to be met where they're at. So I think that's one of the big things that you see in collaborative care that's so different, is that we're actually able to create a system and work within the fidelity of this model to say we're able to have folks come be met where they're at and utilize the specific techniques like the systematic caseload review to be able to increase our reach, right? So instead of that one-to-one contact I might typically have with the psychiatrist, I'm able to have an impact and support my colleagues like Kara, like Dr. Jones, in doing their work and affecting change in a patient.
Let me just, one of the things that I'm really curious about, if you could speak from kind of this population lens, how this helps address the entire population.
Yeah, so I think collaborative care, really one of the core principles is population level health. So oftentimes when we're delivering direct patient care, we're really only focused on that person that's in front of us and how we can help them, which is incredibly important, and that's the reason that we went into this work. At the same time, there is the feeling of burnout that comes from working in that space when you're not able to meet the needs of the community at large, when you see folks continuing to be in this cycle of care and not being able to access it. So from a population standpoint, utilizing things like a registry, we're able to look at a larger view of the patient population that we're working with. We're able to see how quickly folks are going from having these elevated PHQ-9s, having this uncontrolled anxiety, to seeing their remission and creating relapse prevention plans with them to transition them out of the program. You know, one of the studies that you look at for collaborative care is how much quicker that folks are responding to treatment. Sometimes it's 3 times faster than what you would see in traditional care models. It's not just because that we're really good at what we do within the collaborative care model, but it's because of the systematic approach that's constructed there. And you're removing some of those barriers and the gaps, right? In referral-based models, Cyril mentioned, if you refer someone out, the most likely outcome is that they fall through the cracks and they're not seen. And then you're 6 months down the road and they're coming up with their follow-up and you're like, how is that psychiatry appointment that you never made it to, right? So this is one of those barriers that you're able to get rid of by having people be met right where they're at when they need it.
Nice. So Dr. Ward-Jones, I'm going to meet you in the corner out front later. But you really, truly have been an inspiration in helping lead the change towards behavioral health integration, and we saw that in some of your comments at the beginning. Unfortunately, that's not always the case, and several questions from the audience came on this topic. So can you speak to the importance of having leadership's full buy-in for this model to be successful?
Yes, I think that leadership, of course, buy-in is very crucial, particularly with this model. It's a new model, some new service delivery model, and you know, quite frankly, many of us are adverse to change, and I'm one of them. But you know, at the end of the day, I think that it's, you know, probably just the fear of change. But I think, you know, when leaders are involved initially, I think it sets the tone for, you know, just sustainable change and successful adoption of this model for sure. And I think for me, and you know, I am the CEO, but I'm also an internist, and I think for me, you know, I see it, I get it, and that's not always the case, but I think when leadership is in initially, you know, leadership is allowed to secure those resources that are needed, you know, whether it's workforce, whether it's funding, whether it's equipment, but just really kind of boots on the ground, and I am very honored to be able to still see patients and understand, you know, what's needed for the health center. And I will say they probably think, you know, Dr. Jones is going to get into everything, and yes, we do. But we're always going to get in things that are useful for the health center. But also in doing that, I have to make sure that it's aligned with strategic goals, to make sure that it's aligned with what we're trying to do as a health center. And of course, as a health center, all we're trying to do is provide quality, comprehensive health care. one patient at a time, and that's what we're doing. So I think it's crucial for leadership to make sure that you, explain that. And then also when leadership is involved, you foster a supportive kind of culture that, what is needed, and you can provide that support. And then also ensuring accountability and oversight, knowing what is needed, setting the tone, making the commitment. And when you do that, that empowers others to accept the change because they know that leadership has accepted the change, and leadership is willing to put the time in, is willing to put the money in, the resources. So I think it is so crucial to get leadership buy-in, but it must be something that's good for the organization and everyone can really kind of see the vision.
That's critical. And the places where it doesn't work is often when you don't have leadership buy-in. You might have an energetic therapist or somebody do it. So what suggestions might you have for those who are actively trying to engage their leadership?
I think that leadership has to develop a clear communication plan. It has to be clear. It has to be an early buy-in. For us, what we did, and fairly early on, as early as we could, we got the consultants to come down, the doctors to come down, and we met with all the staff, and all the providers, all the nurses, all the behavioral health staff, just to understand what this model is, because the more to understand, the more successful it will be. And I think also making sure that that it's aligned with organizational priorities, making sure that, that it becomes one of our KPIs that we look at. How is this model helping to increase access? And for us in our health center, we have meetings every week to look at our KPIs with our C-suite. So this is talked about. How is this model helping our health center? How is it increasing access? So I think the more you get people to buy in, the more there's, clear communication, that there's early buy-in, that is a part of the organizational priorities and strategic plan, and that resources are given to that. I think the more successful you will be. I mean, we often start things, but if there's not a commitment from leadership, and not just me, because, I'm going to be in the sunset some days, and I won't even be there like today, but things are still going on at the health center. So I think just getting people to buy in and getting people empowered to understand that this is a focus for the organization, but why this is a focus for the organization, and we're all here for one common goal, is to increase access. And we know in the Arkansas Delta that there are limited resources, and there are few resources in a Marble, Arkansas, or Lepanto, Arkansas, or even a West Memphis, Arkansas. And as I stated before, patients don't want to go anywhere else, and for majority of the time, why should they when we can take care of them? But also empowering those providers to feel comfortable, but making sure that there's the wraparound for our patients. And really, we like to say all the time that we try to set up one-stop shopping, and this is one of our tools in our toolkit to make sure that patients can stay within our four walls and make sure that they're taken care of. There's no way that I can take care of uncontrolled diabetes without taking care of their depression. There's just no way that's going to happen.
Thank you, Dr. Jones. I just want to say, I know we're about out of time, but one of my takeaways is we just heard Dr. Jones talk about the leadership that's important. And one of the things that I've seen at East Arkansas is it's not just Dr. Jones' buy-in, as she talked about, but it's the whole team. And so getting to go out there and getting to see how all of you work together and your commitment to providing whole person team-based care truly is inspirational to me. So I just want to say thank you so much. And thank you for embracing this team-based care, because the healthcare landscape is changing. It's changing right in front of our eyes. And team-based models are going to be essential. And working together, as East Arkansas is doing, is absolutely going to be the model, not the exception. So thank you for all you do. Thank you for improving Arkansas behavioral health and for being the pioneers.